Awesome. Thank you all for being here, and especially thanks to John for inviting me to come speak. Much of the work that I'm going to present today is really a lot of work that's been put together by many people in the audience. So John, Kim, Ashwin, Justin Rothmeyer, you guys have been instrumental, the cardiac team here, David Owen, Jordan Prudkin, Jack Salerno, and all the foundations. So the Nick of Time Foundation, Anthony Bates Foundation, Eric Paredes Foundation, Young Hearts for Life. Thank you guys for all the work that you guys have contributed to the success here. So I always love coming back to speak here. Allows me to put on my purple because I like to support UW, so I enjoy coming back to Seattle. Today I'm going to talk about the psychological impact of screening, and especially the three things that I'm going to talk about today are really focusing on the false positive athlete. Then we're going to turn and talk about those that are actually diagnosed with cardiovascular disease. And then I'm going to end with giving you guys maybe some tips on how to communicate with those that are diagnosed with a cardiovascular condition. First, how many people are sports medicine physicians in the audience? Okay, so lots of you guys out here. So when I was trying to prepare for a talk on mental health and athletes, I sort of turned to what I consider the Bible for sports medicine, and that's actually this Clinical Sports Medicine by Bruckner and Kahn. And when I looked at mental health and athletes, unfortunately, there's probably, I think, a paragraph in here on mental health, so I really didn't have a good foundation for starting this talk, and I'm hopeful that the new additions moving forward are actually going to talk about mental health and athletes. And I think we have other leaders here like Ashwin Rao, who's been doing a tremendous amount of work here. So I think we can sort of use the framework of maybe when you think about mental health and think about the psychological impact of injuries, I sort of break them up into three key areas. So you might have sort of someone who gets a sprain, strain, or maybe an ACL injury, for example. And in those individuals, you sort of have a defined time period on when somebody's going to get back to sport. So there is sort of a psychological response to injury, but it's a little, there's a defined period so people know when they might be getting back to sport. Then there's sort of a second category where you have maybe things like concussions, where somebody has a concussion and you sort of don't know how long is it going to take me to get back to sport, and that's sort of a little bit different than your psychological response to maybe an ACL tear. And then the last category that I think about is the psychological response when you're actually restricted or disqualified from sports. And so that's kind of the third, maybe a little bit more of a severe category. So how did we get here in terms of trying to understand or even think about the psychological consequences of being diagnosed with disease? So if we sort of take a step back and look at statements like the 2007 statement here by the AHA, they really talk about things like this. They talk about on ECG screening, finally, false positive diagnosis would generate unnecessary life implications with emotional, financial, and medical burdens for the athlete, including unnecessary anxiety and uncertainty. So really people were just talking about false positive athletes. And then there was a working group of the National Heart, Lung, and Blood Institute back in 2012, which John Dresner was a part of, and they really laid out a framework of how to sort of the knowledge gaps regarding ECG screening. And one of the things they talked about is trying to understand the impact of a screening program. And so I think this was sort of the beginning of really trying to, again, understand what are the psychological consequences of screening. And so for those of you in the audience, I want you to sort of take a step back and imagine yourself when you guys are screening. There's sort of different scenarios that you might come across. And I tried to pull a picture of a young Sanjay Sharma here who might be screening, so that's what this is about. So imagine a scenario where you're screening someone, and you get to an athlete and you say, okay, your cardiac screen's normal, you're free to play sports. So an athlete might say, yes, I can actually get back to sport, I'm good to go. We've all had that scenario. So what about this scenario here where your screen's abnormal? So that can be something about your history, your physical exam, your ECG, for example. You need further testing. Athlete's like, what does that mean? And then, okay, your additional tests are normal, you're actually cleared to play sports. Athlete's like, yes, okay, I can get back to sports. And then there's sort of this last scenario. Okay, your screen, again, your history, your physical exam, or your ECG is abnormal. You need further testing. All right, what does that mean? And then your additional tests are abnormal. You have a heart condition. Your participation in sports is in question. What does that mean? So we're going to sort of walk through this and just, again, envision yourself trying to counsel athletes or think about how you might react in these sort of scenarios. So what we did is we embarked on a journey where we started really talking about different levels. So we started talking about athletes and how do they react at the high school level. Then we talked about, okay, how do they react at the collegiate level? And then we've sort of now done some research looking at recreational and active individuals when they're in the adult life. So this is one of the first studies that we did. We looked at 23 different schools, 1,500 athletes at 19 different sports. And in these studies, what we did, we had a pre-screening assessment that we gave everyone. And then they went through the screening process, the history, the physical exam, they received an ECG. And then if they needed additional testing in these scenarios, there was echo on site to help with clearance. And after all of the additional testing was completed, if they needed it, everybody received a post-screen psychological assessment at the end. And what we found here is that those who had false positive results actually didn't report significantly different anxiety levels compared to those who'd screened normal. And when you compared the athletes, whether they had a false positive due to something in the history or the physical exam or the ECG, there was actually no difference in anxiety levels. So if you sort of look at that, there was no difference in anxiety levels if you had a false positive due to the ECG when compared to the other elements like the physical exam or the history. But if you take a look at athletes, think about the incidence talk that Kim did yesterday. High school athletes, they have an incidence of about 1 in 80,000 for sudden cardiac death. And for collegiate athletes, especially when you start thinking about some of the high-risk sports like males, African Americans, and basketball players, the risk goes up tremendously. So we said, okay, we have this study in high school athletes. What about collegiate athletes? And this is a study that just came out a couple months ago in the British Journal of Sports Medicine. So we'll walk through some of the results. This is data looking at the pre-screening attitudes. And what we have here is we have things that are on a Likert scale, and if somebody agrees or strongly agrees to a statement, they're sort of above that horizontal axis. And if somebody disagrees or strongly disagrees to a statement, they're sort of below the horizontal axis. And the way this is, we have those that are normal, they're in the dark blue, and those that are false positive, those are in the light green. And what you can see here is that really in all the pre-screening attitudes, their interest in sport, worrying about an underlying heart condition, wanting to know about their conditions, wanting an ECG, actually there were no differences in the pre-screening conditions. So nothing with the pre-screening attitudes. Now we're going to walk through and look at the post-screening attitudes, and this is where things get a little more interesting. So again, if you look at it, normal is in the blue, green is where the false positives are. And so what we can see here is those that when you sort of ask anxiety during screening, you see that there's maybe a little bit of a difference. And then you start looking at some of the things like, was I scared about an underlying condition? That's when you start to see that there may be a difference here. I was worried about being restricted. But there are some positive consequences to actually being screened with an ECG. People actually said they felt safer by getting an ECG compared to screenings in the past that they've had. And they would actually recommend an ECG to others. People were worried about having a future heart condition if they had a false positive result. So that's something to kind of keep in mind. So our sort of conclusion here is that there's increased level of concern in those that have false positive results at the collegiate level. And there is a caveat here in that this study compared to the other studies, and in the collegiate athletes, we actually let them get their echo off-site like normal practice, whereas in the high school study, the echoes were on-site. So there's a little bit of a caveat to know there. If we put this into perspective and we wanted to know about this anxiety during screening, in the normal individuals, it was about 13% that they described anxiety, and it was 21% in those that had a false positive result. So really not that different, but there is a difference there. And then if you ask that question again, were they scared during screening, there was a little bit of a difference where it was 9% versus 32%. So that question seemed to get at this level of concern. So is anxiety a reason to avoid ECG screening? I don't know if that 9 and 32% sort of is something that you wouldn't expect in this group. I don't think it was sort of above and beyond. And when you compare ECG false positive results to those that you get with the history and physical, so in our Clemson athletes, for example, about 33% of individuals say that they have a symptom that you might have on the AHA checklist. So in those individuals, you'd have a false positive about a third of the time. So again, when you think about the false positive due to the history versus the ECG, I don't know if I would say that ECG screening should be avoided due to anxiety, especially when you put it into perspective of someone and think about their history and having a third of the time an abnormal response to a history response. So now as we sort of turn the corner and think about not just a false positive individual, but someone with an actual cardiovascular condition, this is why we started focusing on those who were diagnosed with cardiovascular disease. So in this graph here, again, those who agree or strongly agree to a statement are above the horizontal axis. If you disagree or strongly disagree to a statement, you're below the horizontal axis. And you can see here that those that are diagnosed with a disease, they're clearly describing that they have anxiety during and after screening. So really, these people are the ones that I would say are most vulnerable to psychological morbidity. And so we started a study that we began interviewing athletes who were diagnosed with the disease, and we came up with this 4-stage model that helps you understand the reactions that athletes might go through once they're diagnosed with the disease. So there's sort of an immediate reaction, sort of the challenge to the athlete identity when they're first diagnosed with the disease in stage 1. And your typical reaction might include denial, shock, confusion, and anxiety. And then they go from stage 1 to stage 2, where they're beginning to have grief and coping. And so they're sort of trying to understand their disease and what it means. And eventually they progress to the adaptation and acceptance phases in stage 3 and 4, which actually they'll go back and forth between these stages when they have challenges in their life. So for example, if they have kids, or they need to begin taking medications. There's a new challenge to their life, so they need to adapt, and then they may go back to the acceptance phase over time. And then there are risk factors for increased or prolonged psychological morbidity. For example, those who are playing a higher level of athletics, those who are disqualified from sports, those who have persistent reminders, so if they have to take daily medications, or for people who have unanticipated outcomes. So for example, if you go for an ablation, the ablation fails and then they need to either go back for another ablation or have to think about that, the unanticipated outcome, that's when somebody might have an additional risk factor and prolonged morbidity. So that was a qualitative study that we did. We actually added a quantitative component to this. So this is where we added some numbers using the impact of events scale. And the way that I would look at this is if you score a 12 on the impact of event scale, it would recommend monitoring for athletes. And then if you get a 32, that would signify what's called a significant stress reaction. And so you can see that if you look at the impact by the ability to continue participation in the sports, that's where they get to near that significant stress reaction number. So sports restriction and disqualifications are really the ones that we need to be thinking about. And we began trying to break these down into different categories. So if you had a genetically inheritable condition, you had a significantly higher number on the impact of event scale. Or if you had to take daily medication, that was another one, is to think about having a higher impact of event scale. So I find these conversations with athletes to be really challenging, and I was just curious from you guys, how many of you guys have been formally taught how to have a discussion with athletes that are diagnosed with a cardiac condition? Raise your hand in audience. Anybody? Formal teaching. Maybe there are 2 people. I don't think at the sports medicine fellowship level, for example, we really haven't gotten to this to talk about this, and I think that that's something that we need to think about moving forward. And so if you haven't been formally taught how to counsel athletes as far as restriction or disqualification from sports, think about how comfortable do you feel having a conversation with an athlete who's diagnosed with a cardiac condition and may require restriction or disqualification. So how many feel very uncomfortable? How many might feel uncomfortable, neutral? Somebody feel really comfortable or comfortable with this? and then very comfortable. So not many in that very comfortable category. I don't think it's an easy conversation to have. And so we began thinking about how do you have these conversations, and we started to focus on active individuals, so sort of more in the adult, that might be able to tell you a little bit about how should you have these conversations. So we did a study with the manuscript that we're writing right now, and we've looked at about 70 individuals who were diagnosed with hypertrophic cardiomyopathy, long QT syndrome, and some other disorders. And what we found is if you look at the confidence of understanding their recommendations, the majority of individuals would say that they sort of somewhat, really not at all, many of them, about 60%, don't actually feel comfortable with the exercise recommendations that they're getting from their primary care physicians and their cardiologists. And if you sort of look at that with the confidence and the understanding of exercise recommendations and correlate it to their satisfaction of communication that they feel they receive from their medical professionals, they're really identical graphs. And so in an era where we're thinking about value-based healthcare, where we need to be thinking about CG CAP scores and focus on communication, it's really important to think about this because they actually will ask you, right, about your satisfaction with your clinician and how they communicated with you. And I think these results tell us that we actually aren't doing a good job. So again, the confidence of understanding the exercise recommendations actually mirror the satisfaction scores. And in this study, we actually found that the majority of individuals, when they were diagnosed with a disease, they were actually exercising at the recommended level of physical exercise before diagnosis, but when they were diagnosed with a disease, they actually went under the physical activity guidelines of 150 minutes per week. And so I think someone Jordan maybe brought up that we might be trading one disease for another if we don't get people to be physically active somehow. And so that's something to think about moving forward. We've also partnered with folks at Stanford University. So we've done some work with about 55 individuals that were diagnosed with hypertrophic cardiomyopathy. Again, trying to understand what we should be doing for these athletes with regards to communication. And what we found is that similar to the previous studies, the individuals at greatest risk for psychological morbidity were those that competed at a high level, those that had a strong personal identity to being an athlete, and those that experienced a drop in time spent exercising. So again, if you tell somebody and they eventually drop back on the amount of exercise they do per week, for example, they have increased or prolonged psychological morbidity. And so when you ask people, what would you want from your physician or your medical professionals, about 70% of them said that they wanted clearer, more concrete recommendations such as what could be my maximum heart rate or my maximum speed, or some individualized training plan. So this is the sort of communication that people are looking for when they seek help when they're diagnosed with a cardiac condition. It's important for us as people who might care for athletes to understand that when they're diagnosed with a cardiac condition, these are known as what's called a triggering event. And so this is where you need to be thinking about not just the conversation that you're having with them on a one-on-one setting, but really having a crisis plan in case someone has an underlying mental health condition and this triggers them to have sort of something that may require something like mental health counseling. We sort of need to be prepared and have a crisis plan in place once a diagnosis is made. And so thinking about if you're doing a screening program, what are the resources and infrastructure needs that you sort of have to have in place from a mental health perspective? These are sort of 8 things that I would think about on a checklist perspective. I would identify your mental health services team, make sure that you raise awareness that you actually have a mental health team, screen for people if you think that there is a mental health condition that you might suspect. Make sure that your mental health team is communicating regularly with each other. It's probably important to have one person doing medication management. So if you have people who are shopping around to different individuals, that's where things can get a little hairy. So having one person in charge of medications is important. Make sure you have a crisis management plan, especially after hours. So oftentimes there's sort of we're safe between the 8 to 5 time frame, but what happens when it's late at night and someone has a crisis? What do we do there? Think about risk management and legal considerations. And then think about transitions of care. So if we have athletes that are collegiate athletes and then they graduate, what happens to that individual when they move on and they're out of your care? Who do they go to from that point on? In terms of psychological morbidity, we've talked about the restriction from sports, and I'm glad to see that people like Michael Ackerman, with his work on long QT syndrome, that we're now trying to get people back to sport once they're diagnosed with a disease. Jordan just talked about safety of sports with ICDs, and then we've talked now about this new paradigm with shared decision making. And so I think that we might see people get back to sport, where we hadn't seen them in the past. And so that's nice from a psychological morbidity standpoint, because I think that's going to improve the mental health of athletes. So what are some of the best practices that we can do for communication? I think the first thing we can do is we can be like Kim Harmon, and we can take a baby with us to all the screening programs. That's going to that'll make your communication that much better. But some tips that I would have for you guys are to make sure that you do your communication face-to-face. I've actually, when in the course of interviewing athletes, I found that some people actually will talk on the phone to athletes and this when they're delivering a diagnosis. And it's not everybody, but it's just something to know that a face-to-face conversation is important. Make sure that when you're doing your conversation, when somebody hears about a diagnosis, they may sort of forget the rest of what you say afterwards. And so really you need to think about having multiple visits with these individuals. Think about who the support network is for these athletes, whether that's family, friends, other healthcare providers, you as a mental health professional. You guys can do a lot in terms of support and empathy. Think about ways to refocus energy. So athletes are really dedicated and they're focused. And if you can take that focus and shift it to something else, that might give them a new purpose in life. So think about new activities that they can do, mentoring, coaching, for example. Those are all things that can be done to help refocus their energy. And then think about life after competition. As I said, is there a way to give these guys more clear, concrete recommendations, such as heart rate that might be a safe zone for them to exercise within, and then that transition of care after you get done with maybe collegiate sports. What do you do in life afterwards? We've been fortunate with the foundations to be thinking about the support network, and so we've created a program called the Connected by Hearts program. And so this is a potential support network that we have within the U.S. And beyond, where people will share their story. We have heart partner programs, so when somebody is diagnosed with a disease. And so I think this is a way to provide education about disease, support, and also ways to get involved in the community. And it's nice to see that some people who are diagnosed with a disease, even on the national level. This is Isaiah Austin. He was a Baylor Bear, graduated, was going to be a top draft pick in the NBA, and 5 days before the draft actually was diagnosed with Marfan syndrome. But it was nice that the NBA offered him a way to refocus his energy, and so they said that, if you finish college and you'll have a job with the NBA moving forward. And again, I think that's a nice way to sort of refocus his energy. So as we sort of wrap up, I want you guys to leave with three things here. Athletes with false positive results, regardless of the screening modality, whether it's history, physical, or ECG, they may report increased level of concern, but I don't think that the reactions seem overly excessive, and I certainly wouldn't think of it as a reason to avoid ECG screening. I think athletes diagnosed with cardiac conditions are at increased risk for psychological morbidity. I think you need to pay attention to their mental health, and I think that's something that we need to do a better job of and even write about moving forward. And then athletes with cardiovascular disease, in terms of communication, they express a desire for concrete lifestyle recommendations, emotional support, and what can they do from a physical activity perspective in the future. And I'm going to wrap up by playing this audio clip. I really think John Dresner did a fantastic job of being vulnerable yesterday with a case that he had, and I was fortunate enough to be a part of the care for that athlete with John, and really I was just a fly on the wall for most of it. But I think John did an outstanding job in terms of talking to this athlete, providing the support that he needed, both in the moment as well as beyond. And I think that this quote really summarizes how the athlete felt about that and how thankful he was for the support that John gave him.
How I'm doing mentally, rather than like the physical part of it. Like, he knows I have a heart disease. He just wants to make sure that mentally I'm still stable, I'm still functional, I'm still the same person. I think that's more important than anything, especially with somebody that was so dedicated to something, and 2 weeks outside of season starting, everything that I worked for was pretty much taken away. So I feel like it's a lot. It means a lot for somebody to just make sure you're mentally okay rather than physically okay.
Thank you.